All right. Well, thank you, everyone. We have a guest here, I guess. The bedtime didn't quite work out as I planned, but thanks everyone for joining us tonight for this great webinar brought to you by the Ruth Jackson Orthopedic Society and the Women in Arthroplasty Committee of the American Association of Hip and Knee Surgeons. This is the second one. Eva, come on, man. This is the second one in our series about practice management. We had our first webinar last month or a couple months ago. It was about applying to fellowship. And now we're going to speak to you tonight about sort of early career concerns. We have an amazing panel and faculty here for you tonight. So we'll just start off right away with Dr. Melissa Esparza. She's a pediatric orthopedic surgeon at Phoenix Children's Hospital, and she's going to talk to us about networking and finding a job. So take it away.
All right, sorry, I think I was muted too. All right, so my slides here are very informal, but thanks everyone for joining tonight. I feel honored to be included as part of this panel. And when I was kind of trying to think of, what I wanted to put together for the slides, what I wanted to talk about for this talk, I was kind of having a hard time at first because I was like, I don't know that I have any particular expertise or pearls of wisdom other than kind of what I went through myself. So that's really just how I'm going to frame this talk for the next 10 minutes, is just to kind of tell you what I did, what my experiences were, and then try to share some experiences from my previous co-residents and co-fellows, and then also just try to include some advice or wisdom I picked up from mentors along the way. So really just to kind of give you a little bit more background about myself. I'm currently a pediatric orthopedic surgeon at Phoenix Children's Hospital. My practice is pretty general peds right now. I do a combination of trauma, hips, foot, lower extremity conditions, some neuromuscular, and then really have a focus on limb deformity and lengthening. And we're trying to really build up that practice in our program and that program at our hospital. So I'll kind of talk a little bit more about that too, because that has to do with how, I found my job and my job search and everything as well. So to start at the beginning, I grew up in Tucson, Arizona, just a couple hours south of where I am now. Went to the Bay Area for undergrad and med school and decided pretty late to pursue orthopedic surgery, but then ended up going back to Tucson for residency, which I think was really kind of the best thing I could have done. And we really didn't have any pediatric orthopedic surgeons on faculty at my residency. And I was pretty interested in peds early on, but we did our peds rotation up in Salt Lake City, and I made a lot of really great ortho mentors there. And then of course, during my fourth year, I started the whole fellowship application process. And for me, I really kind of look at that now as one of the first steps of kind of starting to network and make connections for your job search. And really even before that, and I think any connections or networking that you do throughout residency, even med school, can definitely end up leading to opportunities and leading to a job for you. So I think that, but I think that with fellowship interviews in particular, I definitely, more than I realized I would ahead of time, met a lot of people, whether it was other residents that were interviewing at the same time, or meeting people during my fellowship interviews that ended up going on to be useful relationships down the line. And so I think, I'm not sure exactly who all of the participants on this call are, but I'm sure a lot of you have kind of been through that process already. But I kind of just say that too, to think of that as, even if you're not formally searching for a job right now, it is something that just by the networking that you've already done, you never really know who knows who, what connections they have. So just always kind of keeping that in the back of your mind too. Yeah, and then just to kind of talk about some other stories of other people that I've heard too. I know people that had ended up finding out about the job that they were at through another applicant that maybe ended up at a fellowship that they initially wanted to go to and match somewhere else, or through people that they met, fellowships that they interviewed at, but didn't end up going there for fellowship, and then ended up taking a job there later. So I think those are all just kind of things to keep in mind as you're going through this process. So I ended up matching for fellowship at TSRH in Dallas, Texas Scottish Rite Hospital, and was super fortunate to have an awesome group of co-fellows there with me. And they really had quite a range of experiences in terms of the job search. So I'll talk a little bit more about, some of the things that they went through, because I feel like for me, I was actually pretty lucky to kind of have something fall in my lap, which I know is not the case for a lot of people. But I think in just kind of seeing a lot of different experiences from other colleagues and friends has been helpful to kind of give advice to fellows that are going through our program right now. So when I finished residency, I actually was offered a position to go back to Tucson as faculty after fellowship. I would have been the first peds ortho on faculty at the academic center there, really in the last few decades, but would have been able to kind of help them to build up their peds ortho program there. And that was pretty tempting at first, just to kind of sign the contract right away. They actually would have given me a sign-on bonus if I had done it right before going to fellowship, but I wanted to kind of hold off, see, how fellowship went and where I wanted to be and all of that, and just keep my options open. And so I was really, honestly, a couple of days away from just signing that contract when I was in the middle of my fellowship. But ended up getting a text from a previous co-resident saying, hey, I just started at Phoenix Children's. It's really great here. I think you'd really love it. And there might be an opportunity opening up here. So again, this is my partner over in the corner here, Dave Bennett, who was the one that had reached out to me. And that kind of just goes back to, what someone said to me at some point was, you never know who knows who, and who can end up being providing an opportunity for you. And so, again, I feel really fortunate to have been able to have that opportunity and get the position that I have now. As part of that, they actually asked me at Phoenix Children's if I'd be willing to do some extra fellowship training, a mini fellowship in limb deformity. And it was something that I hadn't been planning on doing before, but that I was interested in. So I was able to go and spend a few months at a couple different places to do some extra limb deformity training. And so I think that, ended up working out really well for me. But I think and thinking about what job you are looking for, what job is going to be ideal for you. I think my next slide here, I kind of have a couple of notes of just things to think about when you're looking for a job. And so for me, when I was kind of deciding whether I wanted to go back to where I did residency or take this other job, a couple things that were benefits in coming to Phoenix for me were having a big group of peds ortho surgeons that I could come and work with and really kind of challenge myself with cases and continue to learn. And so I think that, again, just kind of thinking of what is important to you and what are the things that you really want in practice is going to be a big part of your job search as well. So kind of going back a little bit to just networking and job search strategies, I think starting early on, just at going to conferences and meeting people at conferences. I went as a junior resident, then again as a senior resident to IPOS, one of the annual Peds Ortho conferences, and was really able to meet a lot of mentors there and make a lot of connections that ended up being really helpful down the line. So even early on in residency, I think it's something that can end up being valuable down the line. I had co-fellows or co-residents that really needed to be in a specific geographic location because their spouse was there or they had family in a certain area. And because they needed to be in a certain city, really just looked at institutions that or practices in that area, and made some cold calls or emails, or asked asked attendings that they were working with to make some calls for them and reach out to people at those places. Of course, there are online job postings on some of the websites, and so kind of checking back at those every once in a while can be useful. And then I think also just kind of being open to if there's not something that kind of falls right into your lap, like I was lucky enough to have, kind of being open to seeing what are other things you can do to kind of make your application stronger in the meantime if you haven't found something right away. And I actually know a couple people that did that. So one of my co-fellows, who I would have thought would have been kind of the first of us to find a job, she ended up doing a couple of little mini fellowships like I did in limb deformity, and had some opportunities early on, but kind of waited it out because they weren't necessarily the best fit for her, and ended up doing 6 months in between when we finished fellowship. And I think it was actually even a little more than that, where she was able to do some extra fellowships. She was able to get like a temporary position actually where we did fellowship, and then was offered a position at Johns Hopkins where she's at now. And so I think that's another part of it, is just, not to get discouraged if you're not finding something right away or something's not the right fit. And then also just kind of remembering that there's a lot of people that really don't end up staying at their first job in the long term. So if there's something that's not a perfect fit for you, I wouldn't worry that that's, the end all be all of all of this. And then again, just kind of going back to things to consider when you're looking for a job, I think something that can be helpful is just making a list for yourself too of, what are the non-negotiables? What are the things that you really need to have? Do you want to be in an academic or private practice center? Is there a region or a city that you really need to be in, or are you willing to, travel to a new place? Of course, family obligations. What does the call look like at different places? What's the compensation? The types of cases or ability to do the cases that you're interested in doing. So for me, I've really been able to have a focus on limb deformity, which is a pretty narrow subspecialty within peds ortho, but in going and doing some extra fellowship training, that really allowed me to be able to do that in my job as well. And then who are your partners going to be? Are you going to have opportunities for mentorship to advance your career? So I think there's a ton of different things that may or may not be important to you, or might be in the future, and you kind of just have to know for yourself what are those things, and where did they kind of rank on your list of what you're looking for when you're looking for a job. So that's all I have for now. I kind of tried to keep it brief, but.
Thank you very much. That's great. These are all amazing tips. Just that one slide, I think, says it all. So that's perfect. So really appreciate it. So next we're going to hear from Dr. Wendy Wong, who is a hip and knee surgeon in Northern California, and she's going to talk to us about contract negotiation. And are you able to screen share?
Wendy, do you want me to bring up your slides? Yeah. I did get them in your email too.
That would be great. Thanks. I'm still having issues. Apologize. So while Melissa's
I can't, are you talking, Wendy? I can't hear you. Can anyone else hear her?
Yeah.
Okay.
I don't know if Eileen, you can bring it up also if Melissa's having trouble. I apologize, guys.
That's okay. I think I got it now.
Thank you. Contract negotiation, it's a important part of getting your dream job. Next, please. no financial disclosure. Next, please. So let's get down to it. Everybody wants to know how much you're going to make after your 26 years of school. So these are just some average numbers, high fives to low sixes to high sixes, depends on what sources you get. These obviously are averages and depends on geography, your type of practice, and how hard you're working. The graph here shows that we're the second highest subspecialty earners, probably third because neurosurgery is not on here, but either way, when you're done, we're going to make some decent money. Next. But the gender gap is real. Females tend to earn less than their male counterparts, no matter what job, what line of work you do, and including healthcare. According to some studies, the gender gap is about 25 to 30%. And if you think about that over a lifetime, 35-year career, that can amount to about $2 million, according to this health affairs studies from last year. This study pulled together JAMA and Doximity data, so probably pretty accurate, give or take, which is why contract negotiation is really important. Next, please. So you need to do some homework. Remember, when you get to the point where you're negotiating a contract, they already want you, your employer or the group. So it's about trying to prove to them how much they want you, whether you're joining a private practice where you're going to kind of make what you kill, or you're going to be an employee for a health system, you still have to be smart about it. So finding out what your employer is looking for, is there a void because somebody retired or left? Are they trying to expand? So they're trying to get new blood to fill the new locations. And do you fit the culture of the practice, right? Is there some specialty needs, for example, limb deformity? Is there something that really is going to set you apart? Usually, if somebody's hiring a new grad, they're looking they expect you to take call because you're going to be coming out, you're going to be thirsty, you want to make money. And so that putting yourself out there and making sure that you're willing to take call, I think can make you more attractive to the potential or to your employer. And then having gone through this recently for our practice, we're about 50 docs in private practice, just ortho private practice in Northern California. We added another total joint surgeon. So basically everyone's looking for a high producer, someone who's going to be low drama, and a team player. So think about that, how to position yourself to be somebody like that. Next, please. And then really taking a time to think about what you want. As Melissa had alluded to before, coming out, you probably just want a real job because you've been a resident for so long. But about 50% of newly graduated docs, I think, change jobs within the first 2 years because they're not happy. And so it's really important to take your time and realize what are you looking for. Location usually is a big one, to be close to family, and then how much you're actually going to get compensated. And we're going to talk about that later. And then in terms of work-life balance, which is important, especially for a female, I hate to say it, but you know, you're trying to be a working mom and the struggle is real. So next. So everybody get their contract and then you scroll to the bottom, right, to look for the number. But there's so much more than just the baseline salary. That's just the base. And what you're gonna be producing on top of that, a lot of times, depends on how it's structured, is probably gonna set you into the next bracket. A lot of hospital employed doctor like Kaiser or health system, they would bonus you based on your productivity in addition to a base compensation. So you want to think about that. A lot of them are RVU based. If you're in private practice like me, it's just basically what you kill is what you get, minus the overhead. And so relocation signing bonuses are very common, especially for orthopedic surgeons. Signing bonuses usually range from 20 to 100. Relocation bonuses I've seen usually from 5 to 15, just on average. And then a lot of them know that you have a lot of loans, and so the health system can help you with that. My husband works for Kaiser, and he got definitely some very good loan assistance coming out of residency. And for a lot of private practice groups, you have a partnership track where you can, after 2 or 3 years, potential to buy in to their ancillary income. We have that for our practice, and it's very profitable. We have our own PT, MRI, or DME, and we have our own very robust surgery center where we do a lot of outpatient total joints. We did probably 500-600 last year, and we're going to do more because of the trend. And so if you're able to buy into it, it's very lucrative. And I would just say that anytime if you're being offered shares at an ASC that is semi-decent run, you should do it. It's a very good return on your investment. And so you want to look at what the potential buying cost is going to be. Is it going to be reasonable, or is it going to be like $250,000 at 2 years, which you're probably not going to be able to afford? And then for a lot of the hospital employed physician, there are going to be a limitation in terms of what you can do outside of your real job. Consulting, is that allowed? Can you do med legal work? Can you moonlight? Can you do locums? Because those are all very potentially very lucrative additional income revenues that you could consider if you wanted to. And then I would say one benefit of joining a big health system is that potentially your retirement benefits would be maybe better than if you're in a private practice, because there are some health systems that still have pension, which is really rare now. And then they would match your 401k. And then a lot of them would offer financial advisor services for free. So think about that. Next, please. And then one thing you really want to think about is the non-financial compensation. Everybody wants to know how much you're going to make, what is the total, but there are so many things that are going to be worth much more than just the number. So if you are looking to have a good work-life balance and you want to be able to have flexibility in your schedule, then you might want to consider something like a private practice where you can make your own schedule versus being an employed doc, right? But then the flip side of that is that in your private practice, you're going to be working a lot because that you're incentivized to work. For example, I can take time off anytime because I'm in a private practice. My husband in Kaiser, he has to talk to his partners. He has to put in his time request like 5 months ahead of time. So think about the trade-offs. And in terms of kind of the culture, if you have a boss, for example, if you're in a health system, you're going to have a boss, right? Your department chair, your whatever chair, are they understanding? Are they good to work with? If you're in private practice, you're your own boss. So think about if you like that kind of control. And then for me, the job satisfaction is a big one. What kind of population you're going to be serving? Is it going to be these hoity-toity people that is going to question everything you say, or is it going to be just really honest laborers that is going to follow your directions? And a lot of times also, whether the hospital or where you're going to be working at is going to offer you your own dedicated teams. So for me as a total joint surgeon, that's pretty important. If you get 2 A teams for your tandem day, it's great. But if you get 2 B teams or C teams, then you're screwed. So, and then are they going to offer you blocks, right? Block time, trying to schedule your cases right off the bat, which has been sometimes hard to get. And then how nice are the facilities? Is it somewhere you really want to work? Is it somewhere you would personally have surgery? And then some of the benefits with health system like Kaiser, they have really good benefits. For example, as a female, a Kaiser allows you to take up to 16 weeks for maternity leave. I've been in private practice, I took 4. So just something to think about. I mean, that's just depends on how many kids you want to have. And then what are your goals, right? Do you want to eventually do like a leadership position? Do you want to do some practice management because you have a business sense? And then if you're in a big center or a big health system, you have a lot of networking abilities, stuff like that. Next, please. And then obviously, this is very obvious. You want to read the contract. It's very long. It's full of big words, but just suck it up and read it, okay, from beginning to end. And be careful. Sometimes they'll ask you to sign an offer letter, which is like, oh, just sign this. It's just to get the process started. But anything you sign is a legal binding agreement. So whatever you sign in the offer letter, if you get offer one, just be careful, read it over. And just remember, verbal agreements mean nothing. They could promise you the moon, and if it's not written down, you're not going to get it. So also, so when I was signing contracts, I had my previous attendings read it over. They're pretty business savvy. They were happy to do that for me. You could hire a lawyer. There are a lot of, people out there if you just do a quick search. And then I would also ask to talk to their recent hires. I was able to do that for my group and see if they're happy. You can kind of get a feel, even if they're not completely honest with you, to see whether there are any red flags to look out for. And then just legally, I know this is a very daunting area for doctors. Some legal terms you want to kind of just watch out for in your contract. So the termination, is there going to be cause or without cause, meaning the hospital can just cut your contract without cause after whatever period, 90 days. So you want to make sure that that's not there, or negotiate for that to be removed. And then what's the time frame? Do they give you a 90-day notice? Is going to be enough time for you to find a new job? And then you want to look at, especially if it's a hospital employed position, once you're terminated for whatever reason, are you going to be able to keep your med staff privileges, meaning join another group and still practice there, do surgery there, see patients there? So that sometimes gets a little tricky. You want to be able to look at their arbitration clause, and then if there's a severance package. And then non-compete is a big one, which means that if you, for some reason, end your contract, is there a certain period of time or distance within a certain mile radius that you're not supposed to practice? You can't join the competitor right across the street. Exclusivity means, are you allowed to do something other than your job, meaning locums, moonlighting, consulting, etc. So you want to really pay attention. I think a typical distance for non-compete is probably anywhere from 5 to 15 mile radius, which might not sound like a lot, but it is. So just pay attention to that. And then we talked about the compensation, how your earnings is going to be. Is it just a fixed salary? Is it pure RVUs like me in private practice, or is it a combination of? And then make sure you look at your insurance coverage for malpractice, or is the hospital going to pay for your tail coverage from your previous job or from your fellowship or whatever it is? So you just want to make sure tail coverage is pretty expensive. It's a one-time cost, and usually it's twice the amount of what you would normally pay for a year of malpractice. So just if they're willing to cover that and your financial compensation is just a tiny bit lower, it might be worth it. Next, please. Okay, so just some quick tips in terms of if you were to do like a face-to-face negotiation, kind of, in the movies or whatever. But I think there are some little tricks that could maybe increase your likelihood of getting what you want. I was reading a few books just on this matter. There is this thing called the priming effect. So if you have a reference or someone that knows your potential employer, you could, before your meeting to negotiate your contract, maybe have them drop a quick line or make a quick comment about how good you are, if that's true. And so you're basically priming yourself, you're positioning yourself to be in a better spotlight, even going into the meeting. There are certain things that you can do that could make you appear more friendly and likable. So smile, dress professionally, be upbeat. You can do a slight eyebrow raise and just a slight head tilt. Those are called friend signals. And be careful, you want to be friendly, but not flirty. Okay, so, and the goal is that you want whoever you're negotiating with to like you, and you're more likely to get what you want. Some of the common ways to show that you're engaged, for example, actively listening, making good eye contact. You can paraphrase some of the words that they say. You can mirror their body language. Those are all good tips for showing the other party that you're willing to work with them. And then you want to make the potential employee feel good about themselves, because you never want to cut them off. You want to let them finish their sentence. You want to make sure that you know that you value their time, etc. And then some of the things I read also include, you want to use open-ended questions. For example, instead of saying, do you think this will work out, which is going to be a yes and no answer, you can say, well, what do you think, how do you think we can achieve that? What advice would you give me? So that allows them to tell you more information than just a pure yes and no. And then when things kind of are hitting, getting stagnant or hitting kind of a stalemate, you can say something like, it seems like, more neutral phrases. It seems like we're hitting a wall here, instead of saying, pointing fingers to saying you and me, you can just be more neutral. And then I think a lot of times, if you just want to, you make it a point that you just want to be treated fairly, right? So a fair market value is a good starting point. Say that you just want a fair compensation, which would be acceptable to both parties. Sometimes you can bring in a third-party negotiator on your behalf. And then one of the books says that if you actually come counter with a range of numbers, this is talking about salary or something that's a little bit of an odd number, you have a higher likelihood of being accepted because you're offering a range. So instead of saying, okay, $550,000, you can say $556,500 or something like that. It also makes it seem like you've put more thought into it. And then never accept the first offer because anything's negotiable. And then try in every situation to get a win-win situation where you're getting kind of your priorities and they're getting their priorities. And then lastly is that you got to take your time. Don't feel rushed that you need to make a decision now, even though your potential employer might want you to get going and just sign right there. You can say, you know what, thank you for your offer. I would like to take my time. Can I please get back to you later this week? And then make sure then you actually get back to them. So you're not just flaky, you follow through. Next, please. So lastly, just have the right attitude. I think it's very important for a female to navigate the space and be likable, but not appear bitchy, right? So you want to be confident, you want to be professional, but you want to be also friendly and someone that they want to work with. And then there are some books that I listen to. If you guys are interested, they're good resources. Thank you.
Thank you so much. That was great. We're getting some good questions too in the Q&A. So we'll keep an eye on those and we'll address them at the end when we have our big Q&A panel. So we're moving on in the interest of time. Next, we're going to hear from Dr. Ashley Bassett, who is a sports surgeon from New Jersey, who will talk to us about building your practice.
All right. Hi, everyone. Thanks for inviting me to be here today. So I'm going to talk about building your practice. So a little about me just to start. So I went to medical school at Robert Wood Johnson Medical School. After graduating there in 2013, I did my residency at the Harvard Combined Program and then completed a sports fellowship at the Rothman Orthopedic Institute in Philadelphia. After finishing my fellowship, I joined a private practice in northern New Jersey. Our practice is about a medium-sized practice. We have 15 doctors altogether, 11 orthopedic surgeons encompassing all subspecialties aside from pediatric orthopedics. We cover 2 counties with 8 locations, and I go to 3 of those locations. And they definitely differ in terms of the patient population as well as the volume of patients in that area. So definitely a different approach to building my practice when I started there. And our practice does not take ER call, which is good and bad, and good that I'm not taking ER call for quality of life, but bad in the sense that, especially starting out, you don't have that natural inflow of patients from the ER, call pool. So definitely had to come up with different ways to build my practice from the get-go, and I'll talk a little bit about that today. So first and foremost, I'm just going to move this down. There we go. So first and foremost, these are in no particular order, but I do think this is the most important. So be available. So when I was doing my children's rotation in residency, Dr. Peter Waters was the chief of orthopedics at the time. And in our orientation, he said something that really stuck with me. He said, the answer is always yes. And he meant, you get asked to see a consult, don't try to get out of it. You get asked to go check out a patient at the bedside, just go see the patient. Always say yes. But I've taken that, through residency and fellowship and into practice, say yes to your patients as well. So in that respect, get patients in same day. Patients are typically seeking out an orthopedist because they're in pain. They really don't want to wait weeks or even sometimes days to be seen, especially in the case of an acute injury. So getting them in same day is not only good for you in terms of building your practice, you likely have that availability at least early on, but it also reflects well on you and your practice that you care enough about patients to do that. You can go a step further and offer evening or weekend appointments. So I have one evening clinic a week from noon to 8 p.m. This is really good for my patients that work later hours, and especially high school students where their parents don't want them to miss school. That way they can do their after school activities and then see me. So, patients really appreciate this. Weekend appointments really depends on your practice structure. As I said, because we don't take ER call, we do have walk-in weekend clinics, 8 to 12 Saturday and Sunday that we divide up among the 15 doctors. And this is great for MRI reviews or post-op patients that can't wait until Monday, as well as, walk-in acute injuries after like game-related injuries on Fridays and Saturdays. Don't say no to any patients just because they're outside your subspecialty. It can be really tempting. Like, I'm a sports doctor. I just wish my clinic was all sports all the time, but that's just not how it's going to be, especially at the start. So, we all did a general orthopedic residency. We can all see low back pain. We all know how to deal with ankle pain and ankle sprain. So don't say no to patients just because they're outside your subspecialty. They'll typically lead, especially if you do well with them, to other referrals. I saw a patient for her knee arthritis, then I ended up seeing her grandson for his shoulder and ended up doing his surgery. So never turn anyone away. And then say yes to opportunities outside the office as well. And I'll talk a little bit about this in the next few slides. Oh. Sorry about that, it froze. So number 2, spend time with patients. So studies have shown that time spent with patients impacts satisfaction scores and is the most important factor to patients when selecting their orthopedic surgeon. So this just highlights how important it is to patients that you spend time with them, that you listen to them, and that you take time to explain details of their diagnosis and their treatment back to them. But you also have to balance this with wait times. Lots of studies have shown patients don't want to wait longer than 5 or max 10 minutes, or else it impacts their satisfaction scores. So they want you to spend an hour with them, but they don't want to wait longer than 5 minutes. So how do you balance that and run an efficient clinic? Well, the way I do this is by using my team. So when I was in training, like we all were in residency and fellowship, you're doing the intake, right? You're going in and finding out the onset of pain, the position, what they've tried, and then you're presenting it to the attending. Well, in private practice, you don't have trainees and it's just you, but I use my medical assistant for this. So she has a template of all the questions she asks, and then I'm able to go in and say, okay, you've had 6 months of knee pain. It's located towards the front. It hurts with kneeling and you haven't tried anything, no surgery or injections, correct? And that just really saves me time. And then I can let the patients talk about whatever they want to talk about while we move on to the exam. And then always do an exam. It can be really tempting to skip an exam. You have a 13-year-old with, a traumatic anterior knee pain after starting a sport, it's patellofemoral pain, but do an exam. It matters to the patients. And I also use that time to tell them what I'm figuring out based on the exam. If I'm pressing, tenderness over your medial joint line, we may have to get an MRI to look for meniscus tear. I'm already talking about next steps and diagnosis and treatment while I'm doing the exam, so it saves time. So the study that showed that the number 1 factor patients consider when selecting an orthopedic surgeon is time spent also found that the number 1 factor driving patients to the office was online reputation. So your personality and your time spent with them may keep them there, but what's going to get them there is your reputation. And nowadays, more than ever, people are looking online to find out about you. So it really matters that you care about your online reputation. Now, I don't think online ratings are an accurate reflection of physicians whatsoever. I think we all know that unhappy patients are far more likely to go on and air their grievances. Patients that are still in pain or don't feel like they were listened to are going to go on and leave bad reviews. And this is, you can't escape this. In addition to the fact that you can't fix everyone. You're going to have your fair share of narcotic seeking patients, or I'm sorry, but downright crazy patients. So you're going to get negative reviews. So how do you counteract that? And the way you do is by capturing the happy patients and your success stories. And there's a couple ways you can do this. When I started my practice, we gave a handout to all of our patients with instructions of how to go on to health grades and how to leave a review. And maybe I'd hand out 20 or 30 of these a week, and one patient would do it because they leave clinic. It's out of sight, out of mind. I don't know about you guys, but I keep saying I'm going to leave a review for a good hotel or a good restaurant. I've never left a review in my life, even though I promised myself I'm going to. So patients leave and just they get distracted by other things. So just this past year, my practice transitioned to using doctor.com, which I'm not involved with in any way, but we do use them and I think they're really great. So they provide laptops to the clinic that patients use to leave a review. And then that gets synced to WebMD, Vitals, CareDash, Health Grades, like a whole bunch of sites. And this is good for a couple of reasons. One, it goes to a lot of sites. Two, it allows you to capture patients when the good experience is fresh in their mind. They're sitting in clinic. And three, it allows you to capture them before they leave and really increase your number of reviews. If you don't have the ability to do something like this and capture it in clinic, the really good ones to emphasize according to studies are Google reviews and health grades. Those are the ones patients care about the most. But in addition to caring about your online reputation, you also have to care about your reputation in the community. And the best way to do that is to get out there. So you're going to get asked to give talks to PTs or athletic trainers or patients. Say yes to everything. Don't say no to anything. And know your target audience and try to target your talks to that audience. So I usually am speaking to athletic trainers, coaches, teams, because I'm sports medicine. But I did give one talk to an older population at the WIA, and I had several patients reaching out to talk about hip and knee replacement, which is something I don't really do, which is fine, but you want to know the audience that you want to drive into your clinic and speak directly to those. Attend local events, festivals, career days, cover local teams, especially if you're a sports medicine, anything to get your face out there in the community and get to know people. And to each of these things, you want to bring your business cards. They should have not only your name, the number to schedule, but also your office locations. Make it as easy as possible for patients to find you. And then once you build the reputation in the community, you have to maintain it and foster it. So the best way to do that is by communicating with providers, the main one being primary care providers. So even if they didn't send the patient to you, send office notes to PCPs. Nowadays, a lot more patients are just seeking out ortho evaluations independently. They won't even tell their primary care doctor. And the PCPs appreciate being kept in the loop when I send them office notes. As they see more and more of my notes, then they start sending patients my way. So it really does help. Communication with the referral source is really important. They sent that patient to you. They want to know what ultimately the diagnosis and next steps are. And so whether you text them, call them, email them, or just send them the note electronically, you want to close that loop. So I get a lot of patients sent by athletic trainers. They really appreciate being able to just text me, get the patient in same day, get the imaging done same day, and have me call them or text them with an answer within 24 hours. The easier you make it for your referrals, the more referrals they're going to send you. So be reachable and be responsive. Arguably even more important than communicating well with providers is communicating with your patients. And this goes back to time spent with patients, but it has to be quality time. So you want to explain the diagnosis and the treatment. You want to show their imaging. I'm always so surprised when I see second or third opinions and I ask them if they've ever, someone showed you your MRI, right? And they say, no, I've never seen my MRI before. You want to show the imaging to patients. It not only highlights your knowledge, but it allows them to understand their injury better. And then it creates more buy-in when you give the treatment options. They understand and they trust you. But communication doesn't just end when your clinic ends. Medicine, as we all know, especially surgery, it's not a clock in and clock out kind of job. So you have to communicate with them in after hours too. And the best way to make this as easy as possible is having handouts or a website that have your protocols, both operative as well as non-operative, and be detailed. No detail is too small. How often should they be icing? For how long? Exactly when should they change the dressing? These little details are what patients worry about, and having this clearly written out for them alleviates some of that anxiety and makes them happier. And then again, be reachable and be responsive. So I give my cell phone number to all of my surgical patients. I used to give my actual cell phone number. I now give my Google Voice number. It's really easy to sign up through Google. It comes to your phone, like a regular text message, regular cell phone call. So patients know they're reaching on your cell phone, but if you needed to change it due to a bad patient interaction or something, you could, although I haven't had to do that. But this just calms patients. They can reach out directly to me if they have have an issue. And that's important too. I mean, patients may panic when they see a little bit of blood on their incision and go to the ER. And then before you know it, someone's sticking a swab in your fresh incision or taking down the dressing too early. So being reachable not only leads to better outcomes for you, but happier patients. I also call all my patients post-op day one, allows them to ask all of their questions, and it shows that I care. And then lastly, have a great team. A lot of the things I mentioned on the previous slides would not be possible if I didn't have a great team. Spending time with patients and communicating with providers is only possible to have a sufficient clinic because I have a great medical assistant and a great PA. At the start, you're going to be doing everything yourself, and that's how it should be. You're in board collection. So you're writing all your notes and your PT prescriptions and your work notes, and that's okay. But once you pass out of board collection and you start to run more of a busy clinic, you're going to need to delegate tasks. So simple tasks like patient calls about medication questions, PT orders, med refills, all of those things can go to your medical assistant, but you need to take time to train them because they represent you when they're talking to patients. They need to be knowledgeable and empathetic, and they need to know your protocols. And then for post-ops, I put all of my post-op patients on my PA schedule to free up more space for me to see new patients, but I also see all of my post-ops. So my PA, Anna, sees post-ops in her clinic while I'm in clinic with her seeing my own patients. So a 45-minute post-op visit, she takes care of the brunt of that. And then I pop in for 5 to 10 minutes to see patients. They still feel like they got a good amount of time spent with them. And it significantly shortened the amount of time that I had to spend doing the dressing change and fitting the brace and things like that. So my PA Anna is a direct extension of me. And that's really been apparent to me as I'm currently on maternity leave. And she is seeing all of my patients and they're all doing wonderfully. And it's really just because of her that they're all doing so well. So taking time to train her and train my medical assistant has made it such that my patients haven't even skipped a beat. So having a great team makes you great. And I guess we'll do questions at the end. So thank you for your time.
Thanks so much. That was really great. A lot of good tips. I also call patients post-op day 1 or 2, and it's a really good chance for them, as a hip and knee surgeon, sometimes they'll be like, aspirin, what aspirin? So
yeah,
it's a good chance to just not only make them feel like they're being appreciated and reached out to and cared for by the surgeon, but also to really get the chance to reinforce any post-operative instructions.
Yeah, they're like post-op instructions. I was supposed to read that? Yes.
Yeah, exactly. Oh, I was just about to step into the bath. So glad you called. So next, speaking of post-op and operating, so we are so privileged tonight to have 2 experts on operating room techniques and tricks to improve your efficiency in early career. Dr. Sarah Wallace, who's a hip and knee surgeon at University of Chicago, and Dr. Kelly Middleton, who's a sports surgeon in Atlanta. So we'll start hearing from Dr. Wallace about her tips to sort of master the OR in the first 2 years, and then we'll hear from Dr. Middleton as well. And I'm really excited to hear both of these perspectives.
Hello, can you hear me? Perfect. I'm Sarah Wallace. I'm at the University of Chicago, and as Anna said, in hip and knee reconstruction. I'll try to make this brief because the rules are very basic. It's essentially what you learned in kindergarten, right? So how to be successful in the OR: make friends, do not blame others, do your homework, be flexible, and be available. And you've sort of heard a lot of this throughout as common themes. So this is my son and his best friend. You don't have to be best friends with everyone in the OR, but you certainly need to learn their names, right? You need to know the names of the nurses that you're working with and the techs that you're working with. You need to learn the names of the anesthesiologists and exchange contact information. You want them all to have your cell phone number, so if they have a question about the trays or what you might need for a case, they can reach out to you directly and easily. And just be nice to people. Say hello, how are you? How's your kid doing? How's the new house? Get to know a little bit about everybody that you're working with. And at the end of the day, just be sure to say thank you to all the staff that you're working with. Don't blame others when things are going poorly in the OR. So be the leader in the room. Take responsibility for everything that happens, even if it's, anesthesia forgot to give the antibiotics before surgery. You should say, I'm very sorry that I forgot to communicate to you that the patient was supposed to receive preoperative antibiotics, and just kind of try to command the room by being the one responsible for every aspect of the day. Don't whine. No one likes a surgeon that's standing there stomping their foot and whining about why their equipment's not ready and available. If the day doesn't go smoothly, try to figure out what you can do better the next time after the day is done on your own time. Worry about it later. And if you were prepared but the staff wasn't, try to figure out a better way to communicate your plans to staff in advance of the day of. And if you do have repeated issues with people in the operating room, take it up with management at the end of the day. Don't cause a big uproar in the middle of the operating room. I know we've all seen things like that happen, and it's just not appropriate and doesn't get you anywhere. So do your homework. This is an example of some case planning that I sent to my scrub techs last week. The equipment that we would need and what the plans were for the implants, and just kind of details step by step. I send this to my physical therapist and the hospitalist and everyone, so that everyone's on the same page a week before the surgery. And if you don't have time to do something like this, say it's an add-on case, just get a Post-it and write for the nurse, here's what I'm going to need for this case. You know, and they'll be very appreciative, and it will go a long way to making you more efficient in the operating room. Be flexible, negotiate for a block time, but you want to make sure you fill that time. Otherwise, your department could be dinged for not having good use of the operating room. So only ask for what you'll safely use. And if you get block time on a Friday night at 10 p.m., which I always joked was my first block time, just go with it, you know, and joke about it and say, okay, it's Friday Night Lights. Here we are again, 10 p.m. on a Friday. Let's just get this done. And the staff will really appreciate it, because a lot of people don't want to be there at 10 p.m. It's not just you, and just make it happen. And the other thing is that if you add on a case, just follow through and do it. The staff, I think, will start to call your bluff if you say, okay, I'm going to add on this case. It's super urgent. It has to be done tonight within the next 2 hours. And then if an hour and 45 minutes rolls by and you say, never mind, I'm not doing the case. I'm going to bump it till tomorrow. That's not going to go over well. And in the future, they're going to start calling your bluff and saying, let's just push this off a little bit. Dr. Wallace will cancel it, and then we'll be able to do it in the morning. You know, so if you're going to add on a case, stick to your guns and just follow through and do it when you say you're going to do it. The other thing is be available. And this is, again, a common theme I think that's come up many times tonight. But when a colleague asks for your help, the answer is always yes. So I'm constantly getting text messages at 5 o'clock in the morning from the trauma service saying, can you do a total on this patient that has a hip fracture? Yes, every time. Even if you already have a full OR day, just say yes. And now I get all the hip fractures that need totals, and that's great because it builds my practice. And early on, I think it's, you know, it's very important to be the yes man, so to speak. Be grateful for every case that your partners give you. I always joke around with one of my senior partners about this terrible infected total knee that I ended up operating on 5 times my first year in practice. And I always joke with her that, hey, that's 5 cases that you gave to me my first year out of this one single patient. So just be grateful, don't complain. And give your colleagues your direct contact information. You want them to be able to reach out to you, whether it's someone directly within your department or other departments that refer to you. Just be available and go with the flow. As far as perioperative management, you also want to make yourself available to the hospitalist that you work with and maybe the anesthesia team. I love when the anesthesia team calls me the day before surgery and asks me what the plan is for a case. It means that they're going to be prepared, and so the day will flow much better, but they need to be able to reach you in order to have that conversation. And be approachable to residents. If you do end up working with residents or fellows, make sure that they feel comfortable reaching out to you, because you'll avoid a lot of headaches later on if they can feel comfortable asking you questions early. And again, if you are boarding a case on call, be ready to come in and do it, and be ready to be busy on call. If you want to get busy in your practice, just take call and go with it and do cases. So in summary, make friends, don't blame others, do your homework, be flexible, and be available. And I think your initial time in the first couple of years in the OR will be a success.
That was great. No, super and efficient, just like you are in the OR, I bet. Well, let's hear from Dr. Middleton. Any other comments you wanted to add? How can we help? And like I said, I'm 4 or 5 years out in practice. I'm learning from all this too. So how can we help our attendees and new surgeons learn from this? Oh, sorry, you're muted.
Okay, can you guys hear me now? All right, I was gonna say, Sarah, that was awesome. Number one thing that I heard you say was thank your staff, like thank your team. I remember I had one attending in residency, and no matter how horrible the case was or how difficult the case was, like literally at the end of every case, he would thank every single person in the room, and it meant a lot. And my mentor, Dr. Freddie Fu, he did the exact same thing. He would be yelling at everybody in the room for something that they did, but he literally thanked everybody. And so that stuck with me. The other thing is to know names. I agree 110% on that one. No names for different reasons. One, When you know people's names, they feel invested, right? Because you are investing in them, because you actually care. And I'm talking not just your staff. I know the janitors, they give me hugs in the morning. Little things will get done that you didn't expect to happen. When you know everybody from the cleaning staff to the CEO of the hospital, and you speak to them and say hello or just acknowledge them. The other reason that knowing names is super important is if somebody's having a difficult intubation and you need to go and get something, right? Or you're busy, you know, helping out with the patient or with the staff, you know who's in your room. So you can say, Bridget, can you go and get so-and-so? Because if you say, hey, can somebody pick up this, or can somebody go and get the gyroscope, people are going to look around each other, and that 5 or 10 seconds does actually save time. So from a standpoint of knowing people's names, it also helps when you're trying to be a leader in the OR and get things done. So that was also super important. No matter what you do in the OR, I think this is important, and this is something that I have to like get in my Zen zone every day with, is to try to like remain calm. So I used to have an attending that would draw a happy face on every single drape. And I never really understood why until I became an attending. And that's just his way of kind of getting in his Zen zone before the start of the case, because pardon my French, but shit's gonna happen, especially things that you don't anticipate. Your first assist, you especially starting out, you don't get the A-team. You don't get the A-team rep. You don't get the A-team x-ray tech. You don't, they did like chest x-rays in the past and they're coming in your room during a difficult case. You don't get the A-team nurse. She's never been an ortho. And then worse than that, she tells you she hates ortho, right? So you're not gonna get the team that you think that you should have and that you did have when you were a resident and you were a fellow and your attendings were in the room, like, you know, reigning supreme. You don't get that, you get the exact opposite. So I think give yourself that patience and know that, like, you know, nobody else cares in that room about your patient as much as you do. So little things, you know, that you would easily get frustrated about, because at the end of the day, it's your responsibility. No matter what, it's your responsibility. Little things at the end of the day, it's easy to get frustrated about. But if you still kind of maintain that whole flexibility piece, or that patience, that get in the Zen zone, and just expectations, not everything's going to be perfect. Not everything's going to be as you planned it. And it's definitely not going to be how you trained until you get to that, you know, like upper echelon level, which will come. So keep composure. And I say that because that is something that I even have to practice and work on. So I listen to music in the OR. There's actually a study that came out that shows that surgeons who listen to music are more efficient in the operating room and create less errors. So I think that that's huge, because I think of it from an athlete's perspective, that we listen to music all the time. So one thing though, is when people stop paying attention and listening in the OR, that's when I either change the music. So like my go-to during a stressful time is Sade, and people know that. So I've literally had a scrub tech go over to the circulator and be like, put on Sade. So like literally, so, and then sometimes it's time to like cut the music. You're like, guys, I need everybody to focus here. You got to bring it back. And so occasionally, you know, you do have to do that. And no matter what you do, I will say as a woman, whether it's to other women in the OR, whether it's to guys, you guys, at some point you're going to be a bitch, but you know what? You're taking care of your patient. And I tell my staff that, I said, if this was your mom, if this is your son, if this is your cousin, we are doing the exact same thing. We are focusing on this moment. I need everybody to focus on this patient. Let's get done with this case. And so that is tough, because yeah, you don't want to come across as that all the time, but you guys, when you're a leader, and unfortunately as a woman, come on, sometimes that just happens. Like people are going to say whatever they want to say, but at the end of the day, if you care about your patients and if you do a good job, and if you also care about them and you know their names and you thank them, like I was on call this past weekend, I brought donuts. I bring donuts at least one of my 2 days while I'm there. That goes a long way just to show your appreciation, regardless of whether or not they say in the OR or you know, this is a tough case, or, you know, that was whatever it is, you know, that happens, you yourself be a good person and just show gratitude to them. One thing that I helped, I think it's so important when you talk about thanking people too, is my mentor, Dr. Freddie Fu, he used to turn over the room sometimes. And so I got in the habit of doing that. That helped with my turnover, especially, like I said, y'all, we got the team, as Anna said, the team Z, okay? Sometimes when it comes to even turnover, y'all, I went down to SPD. I am the only surgeon in my hospital who has ever been to all 3 SPDs, because I was like, what's going on with my trays that are being contaminated? And how can I help speed up this process? I kid you not. A couple of times people are like, who is she? Like, they're like, who is this little girl down here in SPD? Are you lost, ma'am? But for the most part, when they found out, like, there's a doctor down here, even meeting the staff, they helped with your cases and get you stuff that you need. So it's like those tiny little things that go a long way that you wouldn't necessarily think of. Or when I'm having like a shitty day in the OR, I literally will go down there and say, hey, can I get this instrument? Or let me see what you guys have in this tray, you know, just to kind of, it's an air out for me. It's almost like going back to the basics when it comes to why I do what I do, why I love what I do, learning those instruments that I did when I was a medical student sitting in the OR. So I think that, you know, of all the points too that Sarah said, which are excellent, I think those are spot on. You got to be yourself in the OR, be grateful. Dr. Jim Bradley, one of my other mentors, had said that the 3 A's of any successful surgeon: 1, be affable; 2, able, so have the ability; and then 3, be available. Availability being number 1. So I don't necessarily call my patients on post-op day 1, but what I do is I have a Google number, like Ashley had said, I have a Google number, and I will put my text number, my Google number at the top, and I say, if you have any questions tomorrow, or if you want to check in, just shoot me a text. Otherwise, because I used to call every single day, and yes, that is awesome, and I wish I could still do that. It's just, you got to have that balance too, with like, okay, so if I'm not going to call you every day, and my team's not going to call you because we're working on clinic patients, or I'm taking calls because I do take trauma calls because I love it. But if I am doing that, then something's got to give. So those patient phone calls that I'm not making, I can work out in the morning. But I always tell my patients, I'm just a text away. And so that makes them feel more comfortable, because not a lot of doctors do that, guys, you know? So I think that jumping on Sarah's awesome presentation and everybody's presentation, I mean, I'm glad that I am watching this webinar. You know, that those are the things that I would say in the OR, because the OR is like my Zen zone. It's fun. So, and it should be, but at the same time, we're focusing on our patients. So we got to make sure that we are a good leader.
Thank you. That was brilliant. I was taking notes. The Zen zone, trying to channel that. And I'm also remembering the best, you have the tech that comes up and say, yeah, doc, I normally do eyes. That's like the worst sign when they normally do eyes, like compared with ortho. Yeah, like, why are you here? Anyway, let's thank you, everyone. I would love the chance now to hear from the rest of our panelists. So Dr. Liz Clogg is going to help moderate a brief panel with all our panelists here, and we'll get a chance to address some of the questions from the Q&A and hear some more perspectives from everyone.
All right. Hi, everyone. I'm Liz Clogg. I'm a current adult recon fellow at Vanderbilt. First, I was hoping our panelists who did not give a talk could introduce themselves real quick, just so everyone knows who they are and say what your practice model is. So I think we have Dr. Bellamy or Dr. Bellamy. You want to start?
Sure. I'm Jamie Bellamy. I'm an arthroplasty surgeon at Womack Army Medical Center in Fort Bragg. So I'm the military representative.
And then Dr. Lejean.
Hi, everyone. Claudette Lejean. I'm at NYU Langone. I do hip and knee, adult reconstruction. Been here for a while.
Right,
probably.
Dr. Lejean, I know you have to leave. So do you want to take this first question to make sure we get it answered from the Q&A about how to find a good contract lawyer? And then maybe you can also talk about contract negotiation in the academic setting and how that maybe differs from other practice settings.
Well, so my sister and brother are both lawyers, so I didn't have to look for a contract lawyer, so I can't really answer that question very well. So, you know, get into a family where you have immigrant parents who make you be doctors or lawyers, and that's all you're allowed to do. And then you will have a sibling who is a lawyer, and that usually works out pretty well. But in general, the advice that was given, that Wendy gave, is actually very good. Call your fellowship director, talk to your residency director. Those folks know how to do this. I mean, unless obviously you're joining that practice, then they're gonna, tell you, oh, just work for free. But go talk to those folks who you trained with, because they can help you. I know I did the ISK fellowship, and Norm Scott, even though he's mostly retired now, he still helps the fellows with their contracts, and he's very good at it. So that's a very good way to do that. And in terms of negotiating, I was in private practice for a short time before I was recruited to join NYU, and I was doing a lot of cases. So I pretty much could just ask for what I wanted, because I know they knew I could have just gone right back to my private practice and done just fine. So I didn't have to negotiate as much. But the first thing they offer you, they can afford more probably. So find your worth. Women tend to have to justify their worth a little bit more than men do. And I know Mary O'Connor, who is one of my mentors, when she moved over to Yale, she wrote like a 20-point plan about why she was asking for the money she was asking for. Whereas I think if she were male, she would have just said, I want this much money, and not even, backed it up with anything. So we feel like we have to justify everything. We don't. You're the same surgeon as any other surgeon who's showing up there, who's trained the way you're trained. Probably better, because we're actually going to listen to our patients. So you have to consider that and really feel comfortable in your worth, and do some research. Find out what other people are getting paid. Find out what other surgeons are getting paid. It's not that opaque anymore. You can find out. Oh, and one other thing that I heard that we were talking about is the calling your patients thing. That is really gold. And I don't give them my number, but I check my Epic MyChart like constantly. I'm obsessed. I can't have any numbers on that thing that are not unbolded. It drives me absolutely crazy. So I'm constantly answering questions, but I call everybody over the weekend. So I don't call them the next day. I usually operate Mondays and Wednesdays. I say, I'll give you a call over the weekend. Because usually the hospital calls them, they get like 20 phone calls the first few days, but I call them over the weekend, usually either Saturday or Sunday morning, depending on their religion, because some folks don't answer the phone on Saturday. And they're like, oh my God, Dr. LaJambe, it's you calling me? I can't believe it. And that's when you go over all the stuff, like what's aspirin, and, oh, I was supposed to have poop by now. Like they haven't had a bowel movement in 4 days. Like you have to figure those things out, and that's how you intervene. And they love you. And I tell you, my HCAP scores have gone up.
Great. So I want to make sure we get to these other questions from the Q&A box. We have a question about how long is okay to wait before you accept a job offer once you've been offered a job, while you're interviewing for other jobs. Maybe Dr. Esparza, do you want to answer that one?
Sure. Yeah. I mean, I think it varies. It depends. I kind of talked about my own situation. I had an offer like coming out of residency, and I waited until the spring of my fellowship year, but I also knew that they weren't really looking for someone else. And so I think it depends on, is this, are they actively looking and interviewing other candidates? Is it something that they've asked you for a timeline? And I think it's okay to ask too, and say, I need some time to think about this. Is there a time frame that you need me to get back to you on this? Or that you can say, I'm looking at I am interviewing at some other places. I'm looking at some other opportunities. And so I think it's okay to be transparent about that. And just as long as you have that open communication, I don't know that I have a set like time frame, I would say.
Sure. That's all super helpful. And then Dr. Bellamy, I guess from the military aspect, I know when we did the fellowship panel, someone asked about delaying fellowship to do their military obligation. And, I don't think we had military representation there. So glad that we have you here now. But if you could talk a little bit about how you balance kind of your career goals with all those other service obligations.
Yeah. So with the military, it's a little bit different. You don't get to kind of choose your own adventure sometimes. The military kind of chooses for you. So if the military doesn't need your specialty, then they're not going to allow you to train. With the Army, that's what I'm in, they usually train about 2 people per year in all the specialties. But like some of my friends who are in the Navy, they don't get those opportunities. Sometimes there's a lot less. So it just kind of depends on which service that you go into. If you are interested in sports, I would venture to say you don't even need to do a sports fellowship until maybe you get out, because the military is 90% sports. And for me personally, I didn't like sports enough to do it for 5 years and then get out and do a fellowship. So I ended up doing arthroplasty, and it just happened to be something that was available. I really like arthroplasty, but I also really like trauma, and they weren't training any trauma people at the time that I applied. So I actually had to put that off, and I'm doing trauma on the way out. So after I get out of the military next year, I'm going to do that. So that's how the military kind of controls what you get to do sometimes. And then especially with practice volume and that kind of thing, we're not low volume, I would say, but we're definitely not, you're not going to be able to do 8 to 10 joints a day. That's just not how the military works. You know, I can do 3 in a day with 1 room and be done by 3. So just a little bit different practice. And then deployments as well, you know, that will take you out of your practice for at least 5 months, you know, every 2 to 3 years.
All right, thank you. Dr. Middleton, do you want to talk a little bit about your practice model and, you know, how much control you have over your schedule and sort of, and what type of help you have and how much control you have over what you use in the OR?
Yeah, so my practice model, so I work for a large hospital system here in Atlanta. So my practice is, I do sports, specializing in shoulder, elbow, and knee, but I also love trauma, having trained at Pitt. So I take trauma call. In terms of expectations, you know, I honestly did not know what to expect from an employee-based healthcare system. There's like 3 major systems down here in Atlanta, Emory, the academic one, and then Northside and Piedmont are the biggest one. Then there's some private practice groups spread throughout. I would say one of the biggest challenges, or I guess culture shock, as we used to say, would be the leadership. There's not always a physician who's the department head or the chair who's making decisions about how you practice. But the nice part about being in a hospital-based system is that most of these major hospitals do have a lot of money. So with that, you can do different things. Like there's no set, like you need to use this system all the time. Additionally, for patients, in terms of taking care of patient populations from a wide variety of SES backgrounds, you know, there are financial assist opportunities where you're still being able to take care of patients from just diverse socioeconomic backgrounds, which is also very nice. In terms of what I need in the OR, I asked for it, I requested, and prior to COVID, which was for me like 3 months in practice, but prior to COVID, they were pretty quick on getting everything. Even now, they are, you know, very helpful in terms of getting exactly what you need. But it takes a lot longer. And I don't know, that probably does have to do just with the market and the economy in terms of getting things in. But for the most part, they are receptive to, and they want their surgeons to be happy in order to do their jobs. So from that perspective, you know, getting what you need in the OR, that's a big thing. And if you ask and you have the details, if you communicate well with the management and the OR as well, then it is relatively easy to get what you need. Rarely have I been told no. I've been told a couple of times, like, we'll have to look into that, or yes, we're ordering it, and it just takes a while to come in. But yeah, and then in terms of efficiency, you know, unfortunately, there's probably more efficiency definitely in the OR private practices because of the whole ASCs. When you're in a hospital base, it's not as bad as I would say my rotation when I was at the VA, but the turnover times could be a lot longer. Then, you know, incentive for people at ASCs is like, we get, when you're done, we're all done, versus, you know, in the hospital-based system where it really is like, okay, my shift ends at this time. So like, I don't care what happens up until, you know, 3 p.m. So that is something else that's different in the hospital setting.
Great. And Dr. Wong and Dr. Bassett, do you maybe want to contrast to private practice a little bit?
Yeah, so I definitely have like total control over my schedule. So if and Wendy, I think you mentioned this too, like if you want to go on vacation, you don't have to submit a request, you just close your clinic. You know, if I have a doctor's appointment and I have to come in late or leave early, I just close it and I do it. But again, being private practice, it is a lot of eat what you kill. You know, you can see just one clinic a week of patients, but that's going to reflect in what you bring home. So it definitely is, it's a balance. In terms of the OR, Kelly hit the nail on the head. I do all outpatient. The only inpatient or hospital-based surgeries I'm doing are total shoulders. And even then I'm trying to do them primarily at the surgery center. But if patients are older and they need a 24-hour observation stay, I'll do it at the hospital. But like 95% of my surgeries are at the surgery center. And the efficiency is just, you know, unparalleled in terms of compared to the hospital. Just you can get like double the amount of cases done there because, you know, as Kelly said, when you're done, they can leave. So it just works a lot more efficiently.
Great. We have another question about, let's see, how do you, when you're going out to events, when you're starting practice, put your name out there, how do you not look like a kid with a lemonade stand?
You know, in some of the things you look like a kid with a lemonade stand, especially going to like the festivals. Like I'm in Morris County, we would do like the Morristown on the Green festival, and we would have like a little table set up, and we're giving out like bottles of hand sanitizer that say like Orthopedic Institute New Jersey on it. So it really does feel a little bit like a lemonade stand. And especially starting out, like I just feel like as a female, a lot of times you're going to get like, how old are you? How long have you been in practice? You know, things like that. So it is a little challenging at the start, but as you do more and more of them and meet more people and really get better at highlighting what you do and giving a little spiel about yourself, I think it gets a lot easier.
And one thing real quick, I think you should all leverage what you got, right? So people are going to remember you way more than another old white dude. So if you do a good job, then they're going to be like, oh, it's the little Asian girl that replaced my hip, you know, go to her. So just, you should leverage what you have.
Great, thank you. And Dr. Wallace, do you want to comment on like academic sending and any differences in the things that we've talked about already in terms of, you know, are you stuck to certain implant contracts, or, you know, who has control over your schedule?
I think it's pretty variable from one site to the other. I couldn't really say across the board. I actually have a lot of freedom of choice with that sort of thing, and the hospital's been very accommodating, but that might not be true for every job. So you just need to ask those questions right from the beginning and continue to ask for what you need for it to be successful.
All right, thank you. We have a few more questions in the Q&A. I guess if we'll just finish up. We'll do 2 more minutes and then we'll call it. But when you're interviewing for a job, do you ever advise talking to medical assistants, receptionists informally or incognito? Let's see, Dr. Esparza, you want to take that? Yeah.
Sure, yeah. I mean, I didn't do that specifically, but I think it never hurts to get different perspectives on a job. And so, yeah, I think it's helpful to talk to your future partners, to, you know, if there are PAs, talk to PAs. If you're going for an interview, I think that you can definitely get a lot of information from different people, from different staff, to see, you know, are they happy there? Does it seem like the surgeons are happy there? You know, even residents or fellows that they might work with. So I think, you know, any different perspective that you can get, I think can definitely give you more information and be helpful. But that said, I didn't specifically do that.
All right. And then does anyone have any good answers to the question of how many kids you're going to have if it does get asked illegally in a job interview?
I got asked that a lot, actually, especially by females who are in the position of authority. So be careful. And I just answered them honestly, you know, hey, you know, I want to have a family. I'm not quite sure yet right now. I just want to focus on getting my practice started. But I would say maybe don't be so offended just because you got asked, you know, just kind of work with it.
Great. All right. It's 8:50. We've gone 20 minutes over our time.
We could talk for another like 7 hours. I want to know what everyone's OR playlists are now. Like I have so many questions. So all the panelists, you'll be hearing from me. But no, I really appreciate it. I was realizing I don't think I even introduced myself. So I'm Anna Cohen-Rosenblum, for those that stuck around. I'm the chair of the RJOS Education Committee, and I'm also a hip and knee surgeon in academics, and been so grateful to work with Liz on and the Women in Arthroplasty group to put these together. So there's another webinar coming up for furthering your career. That's going to be geared toward sort of early career surgeons, kind of like myself, a few years out in practice. So stay tuned for that if you're interested. You know, it's not just limited to early career surgeons. So come on down. And thank you everyone for hanging in this late. Really appreciate it. As you see, we've got a lot to talk about. So thank you to the panelists. Thank you to ACAS. Thank you to RJOS. And have a great night, everyone. All right. Bye-bye.
Thanks, everyone. That was great.